Well, Deputy Prime Minister Julia Gillard is one of the government voices out and about selling this big health fix. Minister, welcome to breakfast.
Thanks, Fran.
Julia Gillard, the government's answer to the blame game and cost shifting in the health system appears to be another level of bureaucracy. How is this going to help streamline things?
Well, I certainly wouldn't say it's another level of bureaucracy, Fran. What this is about having a national health and hospitals network with the majority of the funding coming from the national government, but with the management and administration and decision-making happening locally. And I think when people look at their local hospitals, what frustrates them is the cost shifting and blame shifting between levels of government is visible. For patients, particularly patients with chronic illnesses, they're constantly running into problems because of the gaps and holes between what one level of government does and what another level of government does. So an end to blame shifting is good for them. And I think having a focus locally is also good. People look at their local hospitals and they want decisions made closer to where they are.
Maybe that's true, but isn't it also true that there is still Commonwealth money going in, state money going in, so we'll still have Commonwealth and state bureaucracies. We're going to have this new Commonwealth agency set up to work out the formula and hand out the funding to the then 150 plus new local hospital networks. That sounds like a lot more middle-level management in health.
Well, the Prime Minister's been very clear that this reform is to be achieved with no net increase in bureaucrats. And if we look at the way the system runs now, we've got bureaucrats in Canberra, bureaucrats in state administrations, then of course often those state bureaucrats are making decisions very distant from where hospitals are, and many of those bureaucrats, Fran, spend a lot of their time working out how to game the system. So if you're in a state bureaucracy, how can I shove this cost onto the Commonwealth? If you're in a Commonwealth bureaucracy, how can I shove this cost onto the state? We're taking that out of the system with a new structure, a national health and hospitals network, funded, majority funding nationally, delivering services locally. And of course, as a government, we too are saying that we will step up and take 100% of the costs of primary care, the first instance care that people get in their communities, and there are gaps and holes there now because of what we fund, what states fund, and some gaps and holes in the middle.
The gaps and holes that the health professionals seem to be most concerned about, even though they give tentative approval, many of them, to this switch, they're very concerned that it doesn't provide any more money for extra beds, extra doctors, extra nurses. That's the pointy end of the problems in our hospitals as experienced by most Australians.
Absolutely correct, Fran. That is the pointy end. And
so there's no more money for this?
Well, to assist with that pointy end, we're a government that's already increased our expenditure, our share of health, increased it by 50% in the healthcare agreements that we've entered into with states and territories.
With minimal impact on waiting lists?
Well, there is more money in the system, and that money is performing elective surgery, so it is making a difference directly to patients who need care. What the Prime Minister said yesterday, though, and why we've announced this structural reform, is that if we're going to make sure the system works for the future, it's not just about tipping more money in on the basis of creaky foundations. It's about making sure that the structure of the system is right. We will have things to say in the coming period about more assistance in health, but the Prime Minister was very clear yesterday. Unless the structure is right, if you are putting more money in, you are at risk of that money not doing the work that you want it to do. So let's get the structure right. This is the biggest structural reform to health since Medicare, with the ability to make a real difference to patients right around the country. The challenge is there, obviously, for the premiers and chief ministers to respond to it. Some of them have responded with enthusiasm. Obviously, there will be working through of what states and territories think, but the Prime Minister is determined to deliver this reform because it will result in better hospitals and better care for patients.
Okay, I'll come back to the states, but the Prime Minister made a few promises yesterday how this will work and improve things. In fact, he promised that if under the local network system, that if a bloke needed a hip operation and is on a waiting list for 12 months, that the local network would streamline that, would find a bed in another hospital within a reasonable time frame. Now, how can that promise must be made. There's queues everywhere at the moment. Where's a bed going to be magically appear at another hospital?
Oh, well, Fran, when you say there are queues everywhere, there are obviously different circumstances in different parts of the country.
Yeah, but we're not talking about sending someone to another state for a bed. We're talking about sending them to a hospital nearby, presumably.
Well, what that's showing you, though, the different circumstances in different parts of the country, is that we can run our health system more efficiently than it's being run now. And a central part of this reform is having an efficient pricing structure to drive the best possible way of running hospitals. Fran, what this reform also promises is national standards, national clinical standards, which would set the amount of time that someone could wait, that, clinically they can wait that amount of time if a local hospital network was not in a position to end up meeting their need in the clinically recommended time. Then the door is open to purchasing capacity from private hospitals, for example, or making arrangements with nearby local hospitals.
Okay, let's talk about the central price list being drawn up for the cost of every hospital procedure, the efficiency price. A hip replacement in Perth will cost the same as a hip replacement in Melbourne or a hip replacement in Darwin, is that right?
It's going to have weighted into it the efficient pricing, loadings for rural and regional, loadings for characteristics like Indigenous population, which may make a difference to health costs. Sure,
but if we're talking capital cities?
I'm not going to do the work of the pricing authority, and I'm not going to say the price in Perth is the same as the price in Sydney, because, Fran, sitting here, that's a job for the pricing authority. But obviously, as a matter of logic, the further you get from big capital cities, the more difficult it is to attract workforce. Basic costs like getting supplies and other things in obviously escalate.
And what about smaller hospitals? Professor Rob Farnsworth, Chair of Sydney Illawarra Health Service Area Service, this morning is saying this is a potential disaster for small hospitals because if they're reliant on case mix funding, they don't do as many procedures, and so the funds won't come in. Can you guarantee that this new funding mix will not mean the closure of one single hospital?
Well, there's nothing in this reform that is about closing hospitals. This is obviously about driving efficiencies in hospitals, efficient prices, but this reform is not about closing hospitals. Closing hospitals, opening hospitals, responding to population growth, population planning would be in the province of state governments, but inherent in this reform, and this is a really important point, is the federal government stepping up to the plate on capital needs for hospitals. When we talk about a 60% funding share, we're also talking about a 60% share including the capital, and that's been a huge strain on state governments, and over time, obviously, that strain has showed.
And just before we go briefly, that 60% share, that's completely uncapped, isn't it?
Well, the essence of this reform is you have an efficient price, you have a system that meets demand, obviously, demand for appropriate procedures. You're not going to be operating on perfectly healthy people for nothing. But if people need procedures, then there will be an efficient price. If that procedure happens, then obviously it will be paid for. So there aren't artificial caps. You don't say, we'll only do X number of hip replacements when a larger number of people in the community need the hip replacements. You'll pay for the hip replacements that are needed at the efficient price.
Julia Gillard, thank you very much for joining us.
Thank you.
Julia Gillard, Deputy Prime Minister. It's 10 minutes to 8.